It's Mari McInerney from Croaky here at the Medical Radiation Sciences Conference in Adelaide, and we've just been at a workshop led by these two people here. Would you be able to introduce yourselves, please, and what you presented on?
Yeah, absolutely. So my name's Kate. I'm a senior radiographer at Logan Hospital up in Brisbane. I am a diagnostic radiographer through my bachelor's and recently completed a professional certificate in pain science and Master of Advanced Medical Radiation Practice. And my research essentially explored what Australian radiographers understand about pain. Sophie is my sister and was my co-supervisor on that project, funnily enough. And yeah, that's essentially what's brought us together to do this work, because we really identified a pretty big gap in the literature in this space.
Yeah, and it was really just by happenstance, because my background, I feel very excited to be here as the token physio at the at this event. I think I'm the only one. I'd love to know if there's others here. But, you know, really I come from a pain physiotherapy background, and so I work a lot with people who experience pain, and particularly chronic pain. And like Kate, have had a fair bit of training in that area. I'm an APA titled pain physiotherapist, have completed a professional certificate of pain sciences, as well as a Master of Science in Medicine Pain Management through University of Sydney. So very, very interested in this space, and it was really just complete coincidence really that as we got to chatting about, Kate was talking about her work, I was talking about my work, and we kind of unintentionally had this like interprofessional collaboration that meant we were able to stumble into this area and realise that maybe we could put our heads together and figure out ways we can translate some really helpful stuff into practice.
Yeah.
So what's the starting point then for the work, to find out what radiation therapists and others do know about pain? How much do they know?
So I'll start that again. The master study that we worked on together was exploring Australian radiographers' understanding of pain. So what we've gathered from that is that there are some radiographers that have demonstrated or do demonstrate a really high-level understanding of pain and clinical reasoning regarding pain, although generally evidence-based pain knowledge is generally lacking within the profession. So that was really the starting point, just to really consolidate and identify that gap. We had suspicions that given that there are poor pain understandings among many health professions, that probably was going to be the case, but we really needed that literature base and that research and the study to show that it's a problem within radiography practice. So that's kind of where that's at the moment.
Most people might be surprised to think that health professionals don't understand pain. So how is that possible?
I mean, I think most of us will have some sort of intuitive understanding of pain. You know, we've all, assuming you're not one of the very small, tiny fraction of the worldwide population that has congenital insensitivity to pain, most of us have had some experience with pain in the past. And I think the way that we've historically thought about pain makes a lot of intuitive sense. You know, we've always kind of associated it with just tissue injury, and it makes sense why that is, but what's becoming clear is that unless we have that really sort of targeted education and we actually share our more recent research that shows that actually pain is way more complex than just that sort of sensory input, that there's a whole host of things that can impact on it, we don't really get much exposure to that. So it is quite surprising, I think, and like Kate said, there's been a lot of work done in terms of trying to educate and upskill health professionals more broadly in the allied health and medical space, but for some reason radiographers really had been left out of that conversation, which seems very strange to us. We're kind of like, how has no one done this yet?
Absolutely, and we did try and capture that a little bit in our study. So we asked radiographers whether or not they received any pain education during their undergraduate training program, and only about 11% of radiographers reported that they did. So there's clearly a pretty big deficit there.
And what are the implications and the risks really of that in practice?
Yeah, so if we really don't have an up-to-date understanding of pain and really have the more historical understanding that it's pain is directly related to tissue damage or disease, that has huge implications for us in radiography, because obviously we're looking at things from a medical imaging perspective and we're looking for pathology on that imaging. So if we have a really outdated understanding, essentially what it means is that there is a risk that we could rely on image findings to really validate someone's pain, because we're not considering the bigger picture, and that patient may very well be experiencing pain even if there's nothing that we can actually objectively see.
And I think that's really important because we actually do have a lot of research that shows that often people have had really negative experiences with health professionals in the past, particularly in the chronic pain space where, you know, we have stats looking at experiences of patients coming through emergency who have, you know, felt as if a lot of the time that they are dismissed or invalidated, sometimes even assumed to be drug seeking, or, you know, there's a lot of really negative sort of perceptions of people, and I think that then compounds when you might have someone who, to scan them, don't necessarily have any objective measures of injury. The assumption, if we're working in that old model, must be, well, they're either faking it or exaggerating or making it up.
So
and so it really is, you know, we need that updated understanding of pain so that radiographers and any health professional who's working with people who might be experiencing pain can actually understand that it's possible for someone to have pain and to be experiencing that very real pain and to treat that sensitively and with compassion, even where we might not have those objective findings.
Yeah, and you gave in the workshop, it was a fantastic interactive thing.
Thank you.
You gave some really practical examples ranging from language, you know, and this is how for better practice, ranging from language to emotions and thoughts and environmental. Can you give us some of those tips for people for what they can do better?
I would say the biggest one from a person-centered care perspective for me is to actually validate their pain and let them know that you do believe them. That's a huge one for me, I would say, is that if there was going to be a key takeaway as a practical strategy.
Yeah, I think a lot of it comes back to how can we help make the environment feel safe and comfortable in any way we can. So erring on the side of making sure people are comfortable, offering accommodations in exam positioning, which, you know, a lot of radiographers are already doing that. But even thinking more broadly about how someone would feel coming into that environment, because I think we often get very desensitized, I guess, to that environment. It feels normal to us because we spend our time in that clinical setting.
Absolutely.
So thinking about, you know, what does the patient see, hear, smell when they walk into the department? You know, does it feel comfortable and safe? Even just the rapport and I guess the way of communicating with people.
Definitely.
Do you want to maybe elaborate on some of the practical things that, from a communication perspective, that people could do?
Yeah, absolutely. So in terms of communication, there's actually been research that has shown that distraction strategies can really help with a pain experience. So, for example, even maintaining conversation through the examination can really help with that, which is really interesting. Changing the language in particular that we're using as well. So rather than saying, you know, oh, I need to move your arm for this x-ray, making it more of a partnership, like, okay, we're going to do this now. So giving them a bit more situational control, giving them the opportunity to ask questions, explaining the procedure to them, and even subtle things, like I really like the idea of changing the word pain out for something like discomfort, also helps to really de-threaten the situation that you're describing. So really running your communication and the language you're using through that lens of safety and what is going to promote a sense of safety.
Even there was that really lovely paper that we mentioned in the workshop that was looking at pain management strategies, and they talked about the language when doing IV cannulas.
Yeah, absolutely. And so they essentially were looking at, they used a range of strategies like relaxation techniques and distraction therapies, but they did also a specific focus on the type of language that they used during interventional procedures, and they changed terms out, like instead of using a sharp sting when they were inserting a cannula, they turned it out for, I think it was cold tingle, which I thought was really interesting, just to kind of de-threaten that language. Yeah.
And we actually had some really good suggestions from the group as well. I think the discussion at the end was great for us as well,
excellent.
Because people really came up, you know, this idea of really ensuring we're being really compassionate and empathetic, you know, giving people the choice of options, you know, okay, if we're going to take this image, you know, this is why that image is important to do, but we could do it in two ways. We could do it this way, which might involve this positioning, or maybe this other way, which involves this. Which do you think would feel more comfortable to you? You know, so that real preserving the autonomy and that feeling of comfort and safety, and just how you present. You know, I think we underestimate how much we transfer to patients. There's nothing worse than when you see, you know, you go to see a GP or a physio and they're rushing and they bustle you into the room immediately. You're like, oh, this is a bit yuck. You know, that
making them feel like they're the priority. Yeah, absolutely.
So there's so many things, and I think that's the point of this, is that embracing the complexity of pain gives us a platform to really think about all of these different ideas and things we can modify in the environment and the way we conduct ourselves. So it's
Taking that holistic approach to pain management as opposed to the typical things we would normally think about, like exam modification or pain relief, and things that we're already doing quite well.
So as well as looking at those general issues, there's also the added factor of neurodivergence and the need for trauma-informed care.
Yeah.
What are your messages on that?
Yeah, I guess speaking as an ADHD person myself, and I work a lot with people who have experienced, trauma and who are also neurodivergent. I think it comes back to, regardless of the label, we need to be treating everyone as unique and acknowledging that everyone is going to have their own experiences and ways of expressing pain. I think a key thing from a pain assessment perspective is to recognise that, particularly where people may not, in all cases, but particularly where people may not communicate verbally, that there is a risk that if we are, say, working with an autistic person, that their way of expressing pain may not match with what we expect from someone who is neurotypical, and so there is a risk that we maybe dismiss the possibility of them experiencing pain if we're just viewing it through what we consider as normal pain expression. So even some of the things like grimacing and withdrawing, or some of the facial expressions that are often recommended for non-verbal pain assessment, may not necessarily be able to be used to rule out pain for people who are autistic. But I think, talking about the idea of safety and comfort in a session, I think that's where trauma-informed care also comes into it. And really, this should be a baseline standard for every single health professional. It doesn't matter whether or not we know someone's experienced trauma. There is such a high rate of trauma in the population that we have to acknowledge the possibility of that for every single encounter. And what it means for us is not that we're going to be treating trauma itself, but we have a responsibility as health professionals to conduct ourselves in a way that we are reducing the risk of harm and re-traumatizing. So I think one of the really lovely examples that came up in our conversation in the workshop was around disrobing, for example. And we might not think twice about that because it's so normal for us. For me as a physio, as well as for you guys in medical imaging.
It's like almost standard practice, really.
But for people who might have, say, experienced trauma in their past, that can actually be quite a re-traumatizing event and not feel very safe. And so, an example in that is, if you don't need to disrobe them and they don't need to change out of their clothes, do we have to? Not just doing things by default, or if we are making sure that people do really have control and choice in those decisions, and that they are able to participate in a way that allows them to feel safe. And everybody is going to be different. There's no one standard way to do that. It's about talking with the patient and making sure that we're adapting to their needs.
Fantastic messages for across the whole health system, aren't they? Anything else you would like to say, or that you hope people take away from the session?
I would say my key take-home message, personally, thank you. my key take-home message, would be that we have to believe patients when they say that they're experiencing pain, because that is the only way to accurately determine pain, is by asking the patient. That would be my key takeaway.
Yeah, and I think for me it always comes back to pain is really complex. There's so many things that impact on it, and if we can appreciate and understand that, even if we don't understand the really nitty-gritty neurobiology of pain, but if we can appreciate that pain is complex, it just opens up so many opportunities for way that we can help improve patient experiences and things that we can do differently to, help support people better, no matter whether we're working in medical imaging or RT or physio or medical. It's just giving us more opportunities than we didn't have before. So people take that away and they come up with their own ideas. Fantastic.
Thank you both very much.